topic that we've been discussed for today is all about the stability and mobility chain. So when we say stability, it is a may be defined as the capacity to control the position or movement of a joint or a series of joints. And mobility, it is may be defined as the capacity to create the appropriate quality of movement around and across joint or joints. So to further more explain about the relationship between stability and mobility, let's all watch the video.
One of the things we talk about is the stability-mobility continuum. And it's kind of an interesting concept. And if you think about normal movement in the human body, joints are either designed to be relatively stable joints or they're designed to be mobile joints to produce movement. If you look at the hips, our hips are designed to be very mobile. It moves in 3 planes of movement, so sagittal, coronal, transverse plane. The next region we come to is sort of the lumbar pelvic area, or another term we use often in training, the core should be nice and stable. I move to my next region up. Thoracic spine is designed to be mobile, which allows our trunk to turn. Now the next couple things I work out to, scapulothoracic joint. Scapulothoracic joint's designed to be stable. If I go to my next joint out, shoulder, glenohumeral joint. Glenohumeral joint is highly mobile. Next thing out, the elbow, stable. Or if I even drop down from my hips, we had mobile hips, knees as a hinge joint should be stable. Our ankle is mobile. Now you say to me, why is this even important to us? Because that's normal function. Here's what's interesting and what we see all the time, and we can actually even pick up with our SFMA as one of our cornerstones here. And that is when there's problem in a joint, or if a joint flips itself. For example, let's take a very common pathology. Individual has hip osteoarthritis and they start to lose mobility. So guess what? This becomes stable now. There's not movement going on at the hip. All that movement that used to take place here is going to get shifted above and below. So guess what we start to see? Lumbar spine or our core becomes unstable or hypermobile. We go up to the next segment. The thoracic spine becomes stable. Scapulothoracic joint becomes mobile where it used to be stable. We lose motion at the shoulder, or perhaps we drop down. If the hips aren't moving, a lot of that force is going to get transferred to the knee. It becomes now a mobile joint. So what we start to see happening is, and the whole tenet of what we like to look at with our stability and mobility continuum, is that when we identify a joint that's become mobile, or hypomobile, and that part would lack mobility, it's reasonable to assume, or we know, those adjacent joints are going to have excessive movement. Where does a person complain of pain? The joints that have excessive movements. So when a person comes in and complains of low back pain, and we look at it, and through our global assessment, we find out they're not having any movement at all, or there's limited movement at the hips, and we start focusing here, it's reasonable to assume we take the stress off the lumbar spine, put it back where it needs to be. Patients often say to us, well, we don't know why you're looking at my hips don't hurt. And my comeback is, well, of course they don't hurt. They're not doing anything. The hips aren't doing anything. They're stuck. They're not mobile. It's the joints above and below that are taking all the force that's causing the symptoms. So again, we use the stability mobility continuum to try to identify areas where there's mobility restrictions. And then as we set up our treatment program, as we become more efficient in setting up our treatment program, we attack those mobility dysfunctions first. And oftentimes, all we have to do is restore mobility back to the joints where it's not happening, and all these other dysfunctions we see will flip. They'll take care of themselves. The core will come back to be stable, but it's not going to be stable if the joints adjacent to it are driving it to be unstable.
This is the fundamental concept. Stress. Stress is defined as a non-specific response to any stimulus that overcomes or threatens to overcome the body's ability to maintain the homeostasis. Homeostasis, it is the equilibrium of the body's internal biological mechanisms. And stressors may originate from many different sources, but manifest themselves physiologically within the body, or the sources include also the physical, the gravity or ground reactive forces, physiological, the pain, vigorous exercise, glycogen depletion, or dehydration. The environmental, if it is hot or cold. Nutritional, inadequate caloric intake, nutrient deficiencies, or skip meals. And also the psychological or emotional, the sorrow, fear, or anxiety. And also the chemical, blood acid-base imbalance, or lower oxygen supply. And lastly, the social sources, the life events or the personal conflicts. Integrated kinetic chain consequences. These actions are not limited to nerves, instructing muscles to contract concentrically, the shortening, and eccentrically, the lengthening against bones to move joint. So in picture A, shows that the muscles contract in shortening, and the picture B shows the muscles contract in eccentrically or the lengthening of the against bones to move the joints. So, but also involve nerves instructing other muscles to contract isometrically, no change in muscle length to hold a joint position. And letter C defined or shows us there is no change in muscle length. The fundamental movement. The ankle, in contrast, moves through various movements during walking. In the sagittal plane, the vertical plane moving front to back, the ankles move through supination and ankle rolling outward at heel, strike and pronation, the ankle rolling inward as the foot makes full contact with the ground. Flexion at heel strike called dorsiflexion and a form of extension as one pushes off of the plantar flexion. This movement in multiple planes qualifies the ankle as a more mobile joint. Transfer of loads and forces throughout the body. To generate the force, the body requires a stable point from which to create an action and tolerate a reaction. Typically, this represents a fixed anchor point, example given the ground, bench, wall, and backrest of a chair, that allows the body to express the energy it has stored in the muscles, tendons, and fascia as force. The injury prevention. With more than 200 joints in the body, stability is a top priority. If the joints in the body are not stable, the surrounding soft tissue structures and even the bones themselves could be injured. Stable joints help prevent both microtrauma and the acute injuries such as a sprain or fracture, and a repetitive microtrauma or the chronic injury caused by overused or repetitive poor form. So when we say macrotrauma, it is occurs when a force is placed on the body or joint and it exceeds the stability level or ability to maintain stability within the joint. Examples include sporting accidents where impact forces from the ground or from collisions with the opponents are large and results in an injury. However, it may also occur because of the body's inability to tolerate the forces imposed on the body during an activity. Example given is throwing out the back while lifting. And when we say microtrauma, it is a more challenging issue to specifically identify in comparison with macrotrauma. It is attributed to the fact that the injury that occurred to the body could have resulted from weeks, months, or even years. of repeatedly applying a small stress on a body segment that went unnoticed until the accumulation results in an injury. Stability system. Stability within the body can be classified in two ways: the local stability and the full body or global stability. When we say local stability, refers to stability provided by each individual joint with the body, whereas full body stability refers to the overall stability of the body, which is the sum of all the local stability links in the kinetic chain. The four components of Punjabi's model. First is the passive system. The passive system relies on structures that essentially remain consistent in their size, shape, and length, which all contributes to the stability within that joint. For example, if you compare the ball and socket joints of the hip and shoulder, the acetabulum or the socket of the hip is much deeper than the glenoid fossa or the socket of the shoulder. Second is the active system. The active system consists of the muscular system. Muscles actively contract and provide necessary stiffness to a joint by creating tension to aid in stabilization. This mechanism typically consists of a contraction of muscles that cross a joint from all angles. For example, the chest and posterior shoulder muscles contracting will help stabilize the shoulder joint. Third is the control system. The control system refers to the aforementioned software of the body, of the neurological contribution to stability. The control system depends on interpreting the incoming sensory information, or the afferent, and then formulating a plan to execute an action to respond, or the efferent. Lastly is the actively passive system. The actively passive system is composed of the facial tissue and how it is arranged throughout the body. Although previously defined, fascia constitutes as a form of connective tissue that is different from the traditional collagen and elastin tissue found in muscle, but it does contain myofibroblasts, which are specialized muscle cells that can undergo contraction and shortening. The role of posture in the stability-mobility relationship. Static posture, or the how an individual stands, is one of the fundamental way to gather information on the relationship between stability and mobility, as postural alignment demonstrates balance between opposing muscles groups at each joint. The static posture is a reflection of three important elements of the neuromusculoskeletal system: the nerves, muscles, and bones. The muscle balance, neuromuscular coordination, and the mechanical efficiency. Each of these elements is interdependent, and each is essential to the functional stability-mobility relationship of the musculoskeletal system. So, as you can see in the picture, the poor posture if you have a forward head and flat back. Poor posture if you have a forward head, rounded shoulders, and sway back. If you have a good posture, you have a balanced upright posture. To further explain about this, let's hear from go.
Hi everyone, I am Jorica Brittany Tapion Manayan, a BPED 2A student. This is a continuation of our report, which is Chapter 14, Stability and Mobility. I'm going to tackle first about the muscle balance. So, muscle balance in the body performs specific function and each muscle has a counterpart commonly called the antagonist. Example, produce the opposite movement biceps and triceps. In other words, if a muscle or group of muscles flexes a joint, then a muscle or group of joints extend a joint. As mentioned briefly in the previous section, with proper postural alignment, These opposing muscle or groups have a mutually respectful arrangement. Next is neuromuscular coordination. In motor control terms, neuromuscular coordination applies to the relationship between input and output. So input is the information that the body gathers about the position of its parts in space relative to one another, the location of its center of gravity and external environment. So this information is gathered through the somatosensory system. Given examples are muscle spindles, Golgi tendon organs, joint mechanoreceptors, and cutaneous receptors. Also, vestibulo-ocular and visual mechanism, which is in short, ears and eyes. So for your further information or understanding, vestibulo-ocular and visual mechanism is called ears and eyes. The next one is output. So when we say output, it is reflected in either movement or the stabilization strategy that the body uses in response to input. It would be the result of how one processes the input and executes the movement response. So that means coordinating certain muscles to work as the premovers, others to assist, or it's so-called synergist, others to neutralize, and others to potentially turn off and do absolutely nothing. Next one is mechanical efficiency. So, do you have any other idea what is mechanical efficiency? So, mechanical efficiency applies to any system of moving parts. So, the goal is to minimize mechanical stress and energy expenditure. This can be seen in the engineering of some of the finest automobiles in the world through their aerodynamic design, transfers of power from engine to drivetrain, shock absorption, and so on. So compare that with the design of the old steam engines locomotive, for example, where most of the available energy was lost and it took long distances to speed up and slow down. Next one is volume. When we say volume, it is a training applies to the quantity of work performed and is manipulated by time. Example, time under tension, the duration of muscle work, or by the total number of repetitions performed. Example, sets and reps. Time under tension is effectively used with isometric type exercises with proper postural alignment or position are held with isometric contraction for no longer periods. Both should be considered when designing corrective exercises aimed at improving posture and movement quality. Next is intensity. When we say intensity, it is a load or intensity refers to how hard the body or muscles work and is measured by numerous variables that include subjective interpretation of effort, ratings of perceived exertion, amount of weight lifted, speed, or grade completed. However, in the case of improving stability, the load should be appropriately matched to target types 1 fibers as discussed previously. Consequently, the intensity should be limited to light to moderate loads, or no higher than 5 or 6 out of 10 effort. The next one is guidelines for restoring muscle balance and stability and mobility. As a general principle, it is best to restore mobility before addressing stability. Attempting to increase stability at a joint or to a body segment that lacks mobility is more likely to force the body to compensate movement or further limit motion as it attempts to stabilize himself. The next one is increasing mobility. There are three primary ways that can help introduce mobility to the body. First is myofascial release or self-myofascial release. The second one is stretching, and the last one is mobilizing movements. Then, Jill! Myofascial release and self-myofascial release. First is myofascial release is a technique that involves the use of various tools to reduce adhesions or knots with fascial soft tissue, which in turn helps restore tissue and flexibility or movement and reduce muscle discomfort. Common tools used for myofascial release include rulers or foam or other materials, balls of different sizes, shapes, and densities, or hands, knuckles, sticks, or assorted specialty tools. Given examples of Theracane. The next one is self-myofascial release. It is denotes techniques an individual performs on himself without the assistance of another person or health and fitness professionals. The next one is stretching. Stretching, particularly static stretching, has become a highly debated topic within fitness, especially with respect to its benefit before exercise. Yes, because the benefits of static stretching following exercise remain consistent. It promotes greater flexibility that can reduce injury. Static stretching can be either passive or active. The passive stretching involves the assistance of another person or device. Given example is strap, door frame, or ground. To assist in lightening the targeted muscle groups where areas active stretching involves actively contracting the antagonistic or opposite muscles to lighten group being lengthened. Increasing stability. As discussed earlier, improving stability is achieved by either positioning the joints in good postural positions followed by a series of isometric constructions or positional isometrics or through limited ROM exercises in which load and intensity of muscle action are controlled or isolated strengthenings. General guidelines for each these are presented in the following list. First, to perform positional isometric, do the following. The first one is position the joint in a good postural or neutral position. Second is complete one set of 4 to 6 repetitions. 3 is hold each isometric contraction for 5 to 30 seconds within a 2-second recovery interval between each set. The fourth is the intensity of the contraction can vary, remaining fixed at a specific intensity or progressively increasing with each repetition, but should attempt to target type 1 fiber with intensities ideally no greater than a 5 to 6 out of 10 effort. The second one is to perform isolated strengthening, do the following. First, position the joint in a good postural or neutral position. The second is complete 1 to 2 sets of 10 to 15 repetitions. Third, perform a controlled concentric contraction followed by a 4-second eccentric contraction, holding the end range between the two contraction spaces for 2 seconds. The last one is the intensity of the contraction should be no greater than 50% of maximal effort. Next one is mobilizing movements that integrate stability and mobility. When we say mobilizing movements are designed to lengthen the muscle and fascial component simultaneously through slow, controlled, rhythmical movements. This movement progressively lengthens tissue across multiple joints. This technique, however, should only be introduced after some flexibility has been restored to individual joints through a stretching program. Otherwise, whole body or integrative movements may suffer from some compromise because of the limitations that occur at one or more joints. Mobilizing movements are neurologically more complex because they involve both mobility and stability requirements across multiple joints, the two primary mechanisms needed to successfully perform. Second to the last topic is contraction. When we say contraction, it occurs when muscles surrounding joints or agonist and antagonist contract together either through dynamic or concentric or eccentric or isometric action. This creates compression within the joint that brings joint surfaces close together to reduce any unwanted motion at the involved joints or improve stability. So for example, the action of engaging both the anterior and the posterior muscles around the shoulder joint while raising the arm overhead at an intensity that does not restrict movement improves stability while allowing appropriate amounts of movement. The last one is tensegrity. When we say tensegrity, it is the combination of tension and integrity. It is contribute to stability through common sharing that occurs between soft tissue and the bones without compression. It produces stability through tension created by the myofascial components, pulling in opposing directions. An analogy to help explain this concept is to imagine shrink wrap covering a plate of food. Once the wrap is placed over the plate, you pull it at the very edge possible to create tension and secure the food it covers. That's all. Thank you.